is being produced. By the way, I asked Rose to record this lecture, but she's going to give me the copy of that recorded lecture. So anyway, as I've been mentioning earlier, we're going to discuss cerebrospinal fluid, autoregulation of the brain, the blood-brain barrier, of course, the blood-CSF barrier, and other matters that are related to these topics. So here, we're going to start off with this picture. Let me just, if I can just hide my video first so that my internet is better. Okay, so pwede ba ako mag-pointer here? Yes, I think. So first, can you hear me? Just give me heads up if you cannot hear me, okay? Yes. So let's learn about the picture that is being shown on the screen. So we have here what we call the meningeal barrier, which is composed of our arachnoid epithelium. So there are different barriers that we're going to talk about. And when we say meningeal barrier, we have here, as magnified on this picture, the skull. Beneath it is the dura mater. And then we have here the meningeal epithelial barrier. So this is the meningeal epithelial barrier, and beneath it is the subarachnoid space where cerebrospinal fluid will flow. And after the subarachnoid space, of course, we have the pia mater, and then we have the brain parenchyma or the brain tissue. So this is the meningeal barrier. Now, when we say the blood-brain barrier class here, we have the capillary endothelium, and you can see, pag sinabi natin, when we say blood-brain barrier, this is the barrier between the blood or the arteries and veins in the brain and that of the brain tissue. So there is a barrier in between. So why do we need this barrier? So we're going to explain that further later. Now, what comprises of our blood-brain barrier? We have here the endothelial barrier. We have the foot processes of your astrocyte or the end feet and pericytes. When we talk about pericytes class, these are multifunctional mural cells of the microcirculation. They are wrapped around the endothelial cells that line the capillaries and venules throughout the body. You can see in this picture, these pericytes are embedded in the basement membrane and they communicate with our endothelial cells. So these are the endothelial cells. These are present in the smallest blood vessels by means of direct physical contact and paracrine signaling. So these are pericytes. So this comprises the blood-brain barrier. Now, what is that sound?
Doc, when someone is joining po, parang may nag-bell po.
Okay. Sige, I got it. Thank you for letting me know. Okay, so we have the blood-CSF barrier. Now, this is the barrier between the blood and the CSF. So we can see here in this picture the blood vessel, and this blue portion represents our cerebrospinal fluid. And there is a barrier in between them. So what comprises that barrier? We have here some fenestrated vessels. What do we mean when we say fenestration? Fenestration are luminal division of the vessels. So luminal division, and it separates it into a parallel channel which rejoins distally. So we have your fenestrated vessels. In between the fenestrated vessels and that of the epithelial barrier is a stroma. And then we have here finally the epithelial barrier. So those are the different barriers that we're going to talk about. Here in this picture, it also magnified and showed us the glymphatic circulatory system, wherein we can see here the brain tissue or brain parenchyma, and then the blood. So it could be an artery or a vein. And then, of course, we have our cerebrospinal fluid and the astrocyte and feet. So this comprises the glymphatic circulatory system. Okay, now, what do you need to know about the cerebrospinal fluid? When we talk about the cerebrospinal fluid class, ilang ml ba or how many ml of CSF is found in the brain? So we have an approximately 150 ml. Now, we asked how many cerebrospinal fluid is produced per day and what produces it. So per day, we have a total of 500 ml of cerebrospinal fluid being produced, and majority is produced by our choroid plexus. 30% is produced by our brain parenchyma or brain tissue. So we have to remember these things. How is it eliminated? So this is eliminated by the arachnoid villi. I'm going to show you some pictures of the arachnoid villi later. And it is being absorbed by this arachnoid villi going to the dural sinuses. So these sinuses then will drain into the jugular system. So we have your jugular venous system that will be the drainage of our cerebrospinal fluid. And what is the function of our cerebrospinal fluid? So since it's a fluid, it will be for cushioning. Cushioning and meaning it will protect the brain and spinal cord from any form of trauma. So for example, it's like amniotic fluid for our fetus. In the uterus later on, there will be an amniotic sac which will contain amniotic fluid, and it will also provide cushion for the baby inside the womb. So it's the same thing with that of the cerebrospinal fluid. It will cushion the brain and the spinal cord from any form of trauma. For buoyancy, on the other hand, it means this is the ability or tendency to float in water or air or some other kind of fluid. So this is another function of the CSF. What will float? Of course, we have the brain and spinal cord. Also for homeostasis and maintaining normal central nervous system volume. Okay. So the production of our cerebrospinal fluid occurs in the choroid plexus. So this shows us a picture of the choroid plexus. And for the production of our CSF, take note that lipid-soluble substances such as carbon dioxide and oxygen, as well as water, can freely cross the blood-brain barrier. So this is very important to take note. They equilibrate between the blood and cerebrospinal fluid. Now, why are we telling this? Because we will note what is the composition of the cerebrospinal fluid. If carbon dioxide, oxygen, and water can freely cross the blood-brain barrier, then the component of which in the blood and CSF will be the same, or they will equilibrate. Now, how about other substances? How are they transported if they cannot pass through the blood-brain barrier? So these other substances are transported by carriers in the choroid plexus epithelium. Now, take note, the composition of the cerebrospinal fluid is approximately the same as that of the interstitial fluid of the brain, but it differs significantly from blood. I'm just curious, why are others still joining at this time? It's already 10:36. We're supposed to start at 10 a.m. Anyway, protein and cholesterol, take note, are excluded from the cerebrospinal fluid because of their large molecular size. So later on, when we talk about the components of your CSF, you won't find protein and cholesterol. That would be abnormal. This is because of their size, large size. Okay. Here in our next slide, we can see here cerebrospinal fluid excretion. And you have to take note that they may be secreted from blood into the CSF or absorbed from the CSF into blood. We can see here the basolateral membrane and the apical membrane. And secretion can occur because of the polarized distribution of specific ion transporters. So we can see in the basolateral membrane, we have specific ion transporters which are distributed, and as well as in the apical membranes of the epithelial cells. So CSF secretion involves the transport of certain ions such as what? You have your sodium, chloride, bicarbonate. So they pass across the epithelium from blood going to the cerebrospinal fluid. So when we talk about the component of composition of the cerebrospinal fluid, we mentioned earlier that they are approximately the same as that of your interstitial fluid of the brain. but the CSF composition differs with that of the blood, such that in the cerebrospinal fluid, you will find less glucose, protein, and cholesterol. In fact, it is almost negligible to find this in the cerebrospinal fluid. Now, we mentioned the reason why earlier. Sabi natin because this has large molecules. Now, next, in the CSF, you have to take note, class, that sodium is higher in the CSF compared to that of the blood. So, a mnemonic for you to remember this is probably when you taste a cerebrospinal fluid, it will be saltier than that of the blood. Now, let's talk about osmolarity. When we say osmolarity, what is the definition of osmolarity? So this is the concentration of a solution. We see or we look at how concentrated a solution is. And we base this depending on the total number of solute particles per liter. So how concentrated is a certain fluid? So we can see here that cerebrospinal fluid is or has the same osmolarity with that of the blood. So you have to remember these things. So on this table, this is just an emphasis. So we have here, when we compare cerebrospinal fluid with that of the blood, cerebrospinal, in terms of concentrations, so we can see here, CSF, we have your sodium chloride bicarbonate, and they have almost the same osmolarity. Although we have mentioned earlier, mas mataas ang sodium ng CSF. So maybe not as much, but still it has higher sodium. Now, CSF has less potassium, calcium, glucose, cholesterol, and protein, while CSF has more magnesium and creatinine than that of the blood. So, those with asterisk has negligible concentrations in the cerebrospinal fluid. Now, we have mentioned that 70% is being produced by the choroid plexus, but we have to take note that there are other sources of cerebrospinal fluid production, and we call this your Virchow-Robin spaces or your capillary ultrafiltrate. So you can see here on this picture, we see the dura mater, the arachnoid membrane, we have the arachnoid trabecula. Now, for example, traversing this arachnoid membrane is a cerebral artery, and then there are capillaries that are distributing or what do you call that? Gives oxygen or other sorts of nutrients through capillaries within the brain tissue. As we can see here, class, there is what we call a space, a perivascular space. When you say peri, it surrounds a vascular structure, so such as this cerebral artery. So this perivascular space surrounds this cerebral artery, and we call this the Virchow-Robin space. And these spaces are also other sources of producing cerebrospinal fluid. Take note, when this cerebral artery enters the brain parenchyma, these vessels are initially surrounded by your perivascular spaces, and these perivascular spaces are connected to our subarachnoid space. Therefore, they can actually contribute to that of the cerebrospinal fluid. Take note, additionally, some CSF are produced from metabolic water production. Okay, metabolic water production. Now, what is the role of your atrial natriuretic peptide? So, atrial natriuretic peptide. Class, in our choroid plexus, we have receptors for your atrial natriuretic peptide. Natriuretic. No, so what is this? What is this receptor, or what is this peptide? Your choroid plexus express receptors. So as I mentioned earlier, the choroid plexus has receptors for ANP, or atrial natriuretic peptide. And when these receptors are stimulated, they increase the cGMP levels, cyclic GMP levels, and they inhibit cerebral spinal fluid production. So take note, class, ANP, when activated, when its receptors are activated, they do not stimulate the production of CSF. Rather, they inhibit the production of CSF. We also have what we call your aquaporine channels, or AQP1. They are thought to be involved in the production of cerebrospinal fluid. Okay, so on this next slide, we now try to understand or study the circulation of cerebrospinal fluid, and we are going to start with the lateral ventricles. This cerebrospinal fluid will go from one ventricle to another by passing through a foramen. When we say foramen, it means it is an opening. So this is an opening between ventricles. And we're going to start with the lateral ventricles. So when you say lateral ventricles, there are two ventricles, the right lateral and left lateral ventricles. And there is an opening which we call your foramen of Monro, or interventricular foramina. So foramen of Monro. Our mnemonic is Monro, right? So mono means one. So it is the first foramen. So that is one mnemonic that we had. Another mnemonic that I use here is the mnemonic late for a month. For example, yan, late lateral, diba? Late for a month. Do you get what I'm saying, class? Lateral, right? Late for a month. So that's the first flow. So if you remember that mnemonic, you will know that it starts at the lateral ventricles, going through the foramen of Monro, and then this fluid will then pass through the third ventricle. Okay, I hope you get it. There is no first ventricle or second ventricle. We immediately go to the third ventricle. And this third ventricle passes through actually the hypothalamus. So from the third ventricle class, another foramen will have to be passed through by the cerebrospinal fluid before proceeding to the fourth ventricle. And we call this your cerebral aqueduct, or aqueduct of Sylvius, which is found in the midbrain. So again, we call that cerebral aqueduct, or aqueduct of Sylvius. Then the fluid will then pass through the fourth ventricle. And in the fourth ventricle class, there are a number of foramen that we have to remember. So we have at the middle, letter M, middle, median aperture or opening, we have the foramen Magendie. So M is to M. Magendie is middle or median aperture. Well, laterally class, we also have two foramen. So we have the foramen of Luschka. So these are your lateral aperture. So L is to L. Lateral is to Luschka. Median is to Magendie. So it's easy to remember. So these are the foramina or foramen that you have to remember. So from the fourth ventricle class, it will pass through or move on to the central canal. So the central canal, this is already at the level of our spinal cord. So remember, class, that from this foramen, it will also move to the subarachnoid space over the brain and spinal cord, where reabsorption into the venous sinus blood via arachnoid granulation occurs. So it's very easy to remember. So first, we have to remember that it will start in the lateral ventricles, and from the lateral ventricle, it will pass through different foramens. So late for a month, lateral ventricle to the third ventricle, you will have to pass through the foramen of Monro. From the third ventricle to the fourth ventricle, we have the cerebral aqueduct or aqueduct of Sylvius. And from the fourth ventricle, we have your middle aperture or the foramen of Magendie, and the lateral aperture or the foramen of Luschka. And from the fourth ventricle, going to the central canal, which will then protect the spinal cord. Now, absorption will occur at the subarachnoid space through our arachnoid granulation. So I hope this CSF circulation is already well understood by now. If not, then you can go back and study it later. Now, we have already discussed its production. Now we discuss its absorption. Take note, what is important here in CSF absorption is your arachnoid villi. As you can see in this picture, we have your arachnoid villi. What are arachnoid villi? So these are microscopic one-way valves. So you can see in this picture, and they penetrate the meningeal dura and they line the sinuses. So this arachnoid villi resides within the sinuses, especially our superior sagittal sinus. So we can see here your arachnoid villi penetrates the meningeal layer. So this is the meningeal layer. Okay, and then they reside in the superior sagittal sinus or other dural sinuses. And when we say clamps of arachnoid villi, ang tawag natin sa kanila is arachnoid granulations. Okay, these are your arachnoid granulations. So ano nga ba? What is the superior sagittal sinus? So we have to understand this. The superior sagittal sinus, this is an unpaired area along the attached margin of the falx cerebri. So we have here the falx cerebri. It is an unpaired area. And it allows the blood to drain from the lateral aspects of the anterior cerebral hemispheres to the confluence of the sinuses. And CSF also drains through the arachnoid granulations into the superior sagittal sinus, and it's then returned to venous circulation. So when you hear the term sinus, this is actually a form of drainage of the blood and cerebrospinal fluid going back to the venous circulation. So I hope you understand that, class. So here it says CSF is reabsorbed into the venous sinuses via the arachnoid villi. So this is the arachnoid villi. And the absorption is directly related to the CSF pressure in the cranial cavity, meaning the higher the CSF pressure in the cranial cavity, the higher will be the absorption as well. Okay, so we have your lymphatics or lymphatics and cribriform plate. This is also important. We can see here in this picture, I've shown you the cribriform plate. And we have to take note, class, that the most common site for spontaneous CSF rhinorrhea is in the sphenoid, and it is in the cribriform plate. Remember, when you're going to encounter, for example, when you will have your duty in the hospital later on, and there is trauma sa head. There is for example, this is a case of a patient who had vehicular accident, and there is head trauma, and you can see fluid leaking from the nose, which is characterized as clear fluid. Sometimes we have to consider this might be your cerebrospinal fluid. Why? Because of this structure, the cribriform plate, which is the most common site of CSF rhinorrhea. So I want to emphasize that your cribriform plate is part of your sphenoid bone. So if you have discussed the anatomy of the head and the bones of the skull, you will be discussing about the cribriform plate. Now, we also have what we call your transependymal flow. What do we mean when you say transependymal flow? So this is defined as the motion of fluids across the ependymal layer of cells that surrounds the ventricles. So the ventricles here, it is surrounded by cells which we call your ependymal cells. And the motion of fluid, specifically your cerebrospinal fluid, across these ependymal cells will determine or is defined as the transependymal flow. And they consequently penetrate this fluid into the brain parenchyma and adjacent structures. So this is the CSF absorption. So yan, class. So the hydrostatic pressure in the subarachnoid space is greater than the pressure in the dural sinuses. So meaning, if that is the case, then there will have to be, this will facilitate absorption kasi higher ang pressure natin in the subarachnoid space. So the arachnoid villi, this is what we have mentioned earlier, these are one-way valves that open when the hydrostatic pressure of the CSF in the subarachnoid space is about 1.5 millimeter mercury than that of the venous hydrostatic pressure in the dural sinuses. So it's a passive process. So we have here, we class your superior sagittal sinus. Now, what is the hydrostatic pressure in the dural sinuses. So we have 5 millimeter mercury. So this is the pressure in the dural sinuses as compared to the pressure in the subarachnoid space, which is 11 millimeter mercury. So higher ang pressure dito. So the CSF can then move from the subarachnoid space to the arachnoid villi, thereby facilitating the absorption in the subarachnoid space. Okay. Now, here we can see, as I've mentioned earlier, we're going to talk about a little bit of its pharmacology. So we have what we call the drug carbonic anhydrase inhibitor. So for our pharmacology students, or for those who had pre-med in pharmacology, you know that carbonic anhydrase inhibitor is actually a diuretic. So what's the function of your carbonic anhydrase inhibitor? They reduce the activity of carbonic anhydrase. And what is the function of carbonic anhydrase? This enzyme is responsible for catalyzing this reaction. So what is this reaction? This is the reaction between your carbon dioxide and water, which will then be converted into your carbonic acid. This is H2CO3 or carbonic acid, and then converted to your bicarbonate. So this reduces the resorption of bicarbonate from the proximal tubule in the kidney, which causes a direct increase in bicarbonate excretion. So when you're going to inhibit this, then this will reduce the activity of this enzyme, carbonic anhydrase. So if we are going to, the inhibition of carbonic anhydrase will decrease the production of cerebrospinal fluid by 60% by decreasing bicarbonate formation in the choroid plexus. So take note, class, in the choroid plexus, there is a need to have bicarbonate. Remember the picture I've shown you earlier, diba? Sodium chloride and bicarbonate are needed for the production of your CSF. So if we're going to inhibit this and there is no bicarbonate produced, then CSF production will be decreased. Now, this carbonic anhydrase inhibitor is used in a condition called acute mountain sickness. For example, if you're going to climb the Mount Everest in Nepal, diba? So if you're going to climb the Mount Everest, you might experience acute mountain sickness. So just like some of my friends who already had, who went to hike in the base camp lang naman, not in the peak of Mount Everest, but in the base camp, but that's relatively high already. So what are the symptoms? So nagpakwento ako sa kanila, what do you feel when you have acute mountain sickness? So we have headache, also fatigue, and somnolence. So these are effect of early cerebral edema with increased intracranial pressure, and there is a loss of cerebral autoregulation mechanism leading to vasogenic edema. So the headache is like migraine. That is the feeling daw po, para siyang merong migraine. And this is because of the swelling in the brain cells or your edema. Hypoventilation appears to contribute to the development of acute mountain sickness. Of course, as you go higher, there will be less oxygen concentration in the air, which will cause hypoventilation. And this hypoventilation will then add up to the acute mountain sickness. So your carbonic anhydrase inhibitor will then decrease production of CSF, and this will help decrease the intracranial pressure. Diba, nagkakaroon ng edema, there is cerebral edema. We'll learn about the Monro-Kellie hypothesis later, and you'll understand why do we need to decrease CSF production if there is cerebral edema. Okay. Now, in CSF pathology, for example, there is subarachnoid hemorrhage or traumatic spinal fluid taps. Approximately 1 white blood cell is added to every 700 red blood cells. And the presence of the subarachnoid blood itself may sometimes cause irritation to the meninges. So there will be mild to moderate increase in polymorphonuclear cells after several hours that occasionally may be greater than 500 white blood cells per cubic millimeter. We also have what we call your xanthochromia. What do we mean when we say xanthochromia? This is, pag nakita natin yung chromia, it means there is change in color. So xanthochromia is the yellowish appearance of the cerebrospinal fluid, and this occurs several hours after bleeding into the subarachnoid space. This may be caused by certain medical conditions. So most commonly, if you have subarachnoid hemorrhage, so it begins in greater than 4 hours due to hemoglobin pigment lysed from RBC. So if there is hemolysis, the pigment of the hemoglobin will now cause the change in the color of the CSF, which is xanthochromia or yellowish pigment. Okay? Yan. Now, let's move on to what we call your cerebral blood flow. Okay? Yan, cerebral blood flow. Okay, we have your cerebral blood flow, which is equivalent to cerebral cerebral blood volume per unit of time. Okay, so did we get it?
Yes po.
Yes po.
Okay, so ibig sabihin, we are trying to measure how many unit of how many ml of blood is being produced or being perfused to the brain per minute. So you can see here, class, the cerebral blood flow, which is normal, is 750 ml per minute. That's how much blood we give to the brain per minute. Imagine a 1 liter of Coke. 1 liter is equivalent to 1,000 ml. So as you can see here, we give 750 ml of blood per minute to the brain. That is how important the brain is. So this is equivalent to 15% of the cardiac output. That is how much blood flow we give to the brain because the brain is important. Diba? Sana all important. When you're important, you are being given much more of the resources. You will be given much more of their time kapag important ka, diba? But in the case of the brain, much of our cardiac output, which is 15%, is being given to the brain. And the normal cerebral blood flow is 45 to 50 ml per 100 gram per minute, or it ranges from 20 ml per 100 gram per minute in the white matter and 70 ml per 100 gram per minute in the gray matter. So mas marami sa gray matter natin or in the cortex of the brain. And take note, class, cerebral blood flow is highest in the neurohypophysis. What do you mean when we say neurohypophysis? This is the posterior thalamus. Tama ba ako? Neurohypophysis is the posterior thalamus. So it has the highest cerebral blood flow, meaning it's important. Okay, now, when we talk about the cerebral blood flow, another thing that you need to take note is what we call the ischemic penumbra. What happens when we say ischemic penumbra? So if there is less than 10 to 23 ml per 100 gram per minute blood flow to the brain, there is physiological electrical function of the cells begin to fail. We call this your ischemic penumbra. For example, this is the portion, class, where there is less than the normal cerebral blood flow. What will happen is there will be a certain portion of the brain. So the ischemic penumbra actually denotes the part of an acute ischemic stroke that is at risk for progressing to infarction, but it is still salvageable or can be saved if it is reperfused. It is usually located around the infarct core, which represents the tissue which has already infarcted or is ongoing is going to infarct regardless of reperfusion. So for example, there is ischemia, or there is acute ischemic stroke on this portion. We call this the core, meaning this portion has already necrosed or is on the process of necrosing. Whether you're going to reperfuse it or not, it will already die. The cells of the brain will already die on this portion. But when we say penumbra, class, this is the area that surrounds the core. this portion can still be saved, meaning it has not necrosed yet, but if we're going to reperfuse blood at this portion, in this penumbra, we can still save it. Pero for example, if we did not reperfuse and there is still ongoing ischemic stroke, then this area of penumbra is at risk for developing also necrosis. So I hope you understood the term ischemic penumbra. Now, when we say below 8 ml per 100 gram per minute, this is already irreversible cell death. This will already cause ionic membrane transport failure, therefore necrosis. Okay, that's the reason why the brain is important, because for just a few minutes that the brain is not being given the right amount of cerebral blood flow, the cells will die. And that is, you cannot regenerate those cells already. Next, we have your cerebral perfusion pressure. Now, we have to maintain a pressure in order for us to be able to give the right amount of cerebral blood flow. And this is based on the mean arterial pressure, or the cerebral perfusion pressure is computed by the mean arterial pressure less than that of the intracranial pressure. So the cerebral perfusion pressure class is the net pressure gradient causing cerebral blood flow to the brain. And it must be maintained within a certain normal limit, because if you have little pressure, for example, we have to know what's the normal cerebral perfusion pressure. So it is between 50 to 150 millimeter mercury. What happens if it is less than 50 millimeter mercury? Then you will have ischemia. What happens if it is greater than 150 millimeter mercury? You will have hyperemia. So we only want to maintain it at this level, 50 to 150 millimeter mercury. Now, we have what we call the term autoregulation. So what does autoregulation mean? This is a very, very important mechanism of the body, specifically that for the brain, in order for us to make sure that we don't have necrosis. So autoregulation, meaning this is an automatic response of the body in order for it to regulate what? To regulate the blood flow to the brain. So this mechanism is maintained, or the cerebral blood flow is maintained at a constant level in the normal brain in the face of usual fluctuations of blood pressure. So of course, in a day, our blood pressure does not remain to be at normal level. For example, if we do cardio exercises, of course, our blood pressure may increase. If we are at rest, then our blood pressure will decrease. So there are constant fluctuations in the blood, and what helps us maintain the cerebral blood flow is autoregulation. Although this is a poorly understood vascular mechanism, still, it is very, very important. So normally, I've already mentioned this earlier, the normal cerebral perfusion pressure is at 50 to 150 millimeter mercury. Now, we have to understand what is this law. So how do we pronounce this properly? It's Poiseuille's law. Poiseuille law. O diba? Social. Sinerch ko pa yan, class. Poiseuille's law. This is the flow through a rigid vessel, and this is the formula. It is represented by the letter Q. Poiseuille's law is represented by letter Q. So this is the law that says that velocity of a fluid flowing through a capillary is directly proportional to what? So this is directly proportional to the pressure, so letter P, of the liquid, and then the fourth power of the radius of the capillary. So this is the fourth power of the radius of the capillary, and it is inversely proportional to the viscosity of the fluid and the length of the capillary. So the viscosity of the fluid and the length of the capillary. This is the Poiseuille's law. So meaning that it will depend, of course, on the pressure of the fluid. So does it have a high pressure or a low pressure? This is in millimeter mercury. And the radius of the capillary. So for example, in this picture, we have here the mean arterial pressure. So this is the pressure of the arterial arteries. Now, we have an increased arterial pressure. Because of this increased arterial pressure, it will cause the decrease in the diameter of the blood vessel. So there will be, if there is the decrease in the diameter, there will be decrease in the radius of the capillary. And of course, we need to take note of the viscosity of the fluid and the length of the capillary that is affected as well. So these are the things that we need to take note. So for us to know the velocity or the speed of the fluid passing through the capillary. Now, it is very important for us to be able to maintain the cerebral perfusion pressure at 50 to 150 millimeter mercury, meaning the intracranial pressure has to be maintained, and as well as the mean arterial pressure. So what may affect our intracranial pressure? This may be increased by, number one, increase in the blood volume. For example, there is intracranial bleeding. Number two, there may be cerebral edema, or there is increase in the number of brain tissue caused by a tumor. So if there is increased IPC, what happens? It will collapse the vein. It will have decreased effective cerebral perfusion pressure, and it will reduce the blood flow to the brain. So there are times that dysregulation can occur. So if there are certain pathologic states, which we're going to discuss later. For example, I'll give you an example. If there is a traumatic brain injury or ischemic brain injury following, or when we use vasodilator agents such as volatile agents and sodium nitroprusside, this sodium nitroprusside is actually a medication for hypertension. It is used in hypertensive crisis, and it will cause vasodilation. So in these cases, the cerebral blood flow may become dependent on the blood pressure. So if there is low blood pressure, then there will be low cerebral blood flow. And if there is high blood pressure, there will be high cerebral blood flow. This is called dysregulation, meaning the body can no longer function well in its autoregulation process. So as the arterial pressure rises, so cerebral blood flow will also increase, causing an increase in cerebral volume. Also, if there is decrease in blood pressure, cerebral blood flow will also fall. It will reduce intracranial pressure, but also inducing an uncontrolled reduction in cerebral blood flow. Now, there are different ways for autoregulation. Are you still with me, class?
Yes po,
Yes,
Doc.
Doc.
Yes, Doc.
Yes
Yes
po,
po,
Doc.
Doc.
Okay, sige. Now we see in this picture here that there are different ways for us to do autoregulation. We have your myogenic or pressure autoregulation. So we will be discussing the transmural pressure on a blood vessel wall. We also have a neurogenic autoregulation, which we're going to discuss some neurotransmitters. We have a metabolic mechanism or metabolic autoregulation, and endothelial mechanism for autoregulation. So in this slide, you can see here, class, on the y-axis, or on this table rather, on the y-axis is the cerebral blood flow, while on the x-axis, we have the mean arterial pressure. So this will show us how these factors will cause autoregulation. Let's start with pressure or myogenic autoregulation. So when we say pressure or myogenic autoregulation, the arterioles will either dilate or constrict in response to changes in pressure, in blood pressure and intracranial pressure, in order to maintain a constant cerebral blood flow. So what pressure are we talking about? Blood pressure and intracranial pressure. So this is the myogenic tone. It will either constrict or it will dilate. So in the myogenic theory class, vascular smooth muscle within the cerebral arterioles intrinsically contract or stretch by regulating pressure. So for example, there is an increase in intracranial pressure. Tumaas ang intracranial pressure natin. So pag tumaas ang intracranial pressure class, then these blood vessels will constrict so that there will be decrease, or sorry, it will constrict so that there will be decrease in cerebral blood flow, because we would like to maintain, or we would like to have autoregulation, right? So if there is already increase in intracranial pressure, we do not want to increase the blood volume going to the brain, because that will increase again the pressure, the intracranial pressure. So that is how we control, or we autoregulate cerebral blood flow using pressure, or the myogenic autoregulation. Next, we also have what we call your metabolic autoregulation. So how does this happen? So we can see here in this picture, the arterioles will also dilate in response to potent chemicals that are byproducts of metabolism. So what are these chemicals that can cause dilation of arterioles? We have lactic acid. When is lactic acid produced? If there is already anaerobic metabolism. If there is anaerobic metabolism, our body will produce lactic acid. So it will mean that if there is high lactic acid, meaning the body needs more oxygen. Therefore, the arterioles will have to dilate to increase blood flow going to the brain because of this lactic acid. Another byproduct is your carbon dioxide and pyruvic acid, which will then cause the arterioles to dilate, therefore increasing cerebral blood flow. Take note, class, carbon dioxide is a potent vasodilator, and if there is increase in carbon dioxide, it will cause vasodilation. There is decreased blood pressure, but it will increase blood flow to the brain. We're done with the metabolic autoregulation. So we have what we call your neurogenic autoregulation. So when we say neurogenic autoregulation, this involves our autonomic system, or autonomic nervous system, and your sympathetic and adrenergic receptors, which are seen in cortical layers 4 and 5. So what are these receptors? We have your beta 1, diba? We just had this lecture. Your beta 1, beta 2, and alpha 2 receptors are dilators, while your alpha 1 receptors are constrictors. So these are involved. And overall, the sympathetic system only plays a minor role. Unlike in non-cerebral vascular beds outside the brain, they will play a major role. But in the brain, for neurogenic autoregulation, they only play a minor role. So we have here some of the neurotransmitters, your acetylcholine, serotonin, neuropeptide Y, and nitric oxide. These are very important for neurogenic response. So they will either cause dilation or constrictions of the blood vessels depending on the needed response in the body. Okay. So here we can see the different neurotransmitters that are important for neurogenic autoregulation. So 5-HT. 5-HT stands for 5-hydroxytryptamine receptors, or so 5-hydroxytryptamine, or your serotonin. So it is a potent constrictor, and it is antagonized by nitric oxide. We also have your neuropeptide Y. And this neuropeptide Y is will cause vasoconstriction, and it is in association with nitric oxide and the sympathetic system. We also have what we call your VIP, which stands for vasoactive intestinal peptide. You have your peptide histidine isoleucine. These are also vasodilators as well. We have substance P, neurokinin A, calcitonin gene-related peptide histamine, which are vasodilatory, especially substance P. Okay, your substance P is related to pain. Now, here we can see the summary of the autoregulation. We have your myogenic, neurogenic, and metabolic mechanism. We also have an endothelial mechanism, which involves your endothelial smooth muscle cell interaction. But what I want you to remember is this neurogenic response, or autonomic system and neurochemical control, is only a minor control. Overall, what is really important here is pressure and metabolic autoregulation. So I want you to be able to remember that and understand it clearly. Now, this next slide will just show us some This next slide will just show us some scenarios and what will happen with the cerebral blood flow. So for example, when we say hyperemia, emia means blood, hyper means increase. So hyperemia means there is increased cerebral blood flow. Now this is related class to, as you can see here in the y-axis, it pertains to the cerebral blood flow, while in the x-axis, it pertains to our arterial oxygen tension. Remember, the lower arterial oxygen tension, it will then cause increase in the cerebral blood flow. So for example, if it already falls below 50 millimeter mercury for our arterial oxygen, so when it falls below 50 millimeter mercury, there will be a rapid increase in cerebral blood flow and arterial blood volume. Of course, if we detect that there is already decreased oxygen in the brain, we'll have to increase the blood flow to the brain in order to bring more oxygen to the brain. So that's how simple you have to analyze this. Next, we also have the relationship between cerebral blood flow and carbon dioxide. As we have mentioned earlier, as we increase carbon dioxide level, it will cause vasodilation. So if there is vasodilation, meaning there will be decreased blood flow going to the brain as well. Next slide. We have what we call your cerebrovascular reserve, reserva, meaning in excess of what is normally being sent, we still have what we call reserve. So this is the ability of cerebral blood vessels to respond to increased metabolic demand and chemical, mechanical, or neural stimuli. So this is the ability of the cerebral blood vessels to respond to this stimuli. And when we say reserve, okay, this may also be impaired by some factors such as hypertension, diabetes, carotid or cerebral vascular stenosis, and can be an etiologic factor in ischemic stroke. Take note, class, that in the brain, okay, there are certain functionally activated areas. So what will happen is cerebral blood flow augmentation will exceed the small increases in oxygen utilization, and the concentration of the oxyhemoglobin is relatively low, meaning there is an excess supply of oxygen in response to a demand stimulus. This will reflect our cerebrovascular reserve. So kapag merong increase in oxygen demand, there is an augmentation that is being given, and this is now your cerebrovascular reserve. So this picture shows us, class, PET scan, SPECT, and CT perfusion to areas before and after the use of Diamox challenge or your acetazolamide. So what I want to emphasize here is there are different tests to show us blood oxygenation level or the cerebral blood volume in the brain. So BOLD stands for blood oxygenation level dependent. So these are images that shows us the oxygen level that is found in the brain. Okay, now let's move on. This is one of the important part of the discussion. We have here the CSF or cerebral blood flow. This is what I was telling you earlier. This is a very, very important concept that you have to understand. We have what we call an intracranial compartment. So we have the cranium. This is the bone that surrounds the brain. We call that the cranium. And when you say intracranial compartment, this is a rigid container. Of course, in adults, this is already rigid. You can no longer there is no longer molding, unlike in fetus or newborn babies that there are different sutures and fontanelles, and this intracranial compartment can still be adjusted or it can be molded, right? Now, since it's a rigid container, it has 3 components inside, and these components has to be on its normal level in order for it not to affect the other components. So what is contained inside the cranium? Of course, 80% of it contains the brain. All right, 80%. Only 10% comprises the blood and another 10% for the cerebrospinal fluid, giving us 100%. So again, as I've mentioned earlier, these 3 components has to maintain their normal volume. But what happens if, for example, you have a brain tumor, you have a supratentorial mass as being shown in this picture, and the compartment is rigid, as we have mentioned earlier. This will not accommodate the additional tumor or mass. So what will happen, class? The other structures found inside has to adjust, di ba? Kakaya naman kailangan mong mag-adjust. Sino mag-a-adjust? Syempre silang mag-a-adjust para sa'yo kasi nga hindi naman siya, it's a very rigid container. So what will happen? So you can see here, class, there will be displacement of the structures such as the lateral ventricles. Instead of being midline, they are being displaced to the other portion of the brain. We have your tentorium cerebelli, as you can see here. Your tentorium cerebelli, as you can see here, there will be a herniation. The cerebellar tonsil will be herniated outside the opening, which is the foramen magnum. So that is what happens if the components of this rigid container or the intracranial compartment, if one of the components is increased. This is where Monro-Kellie hypothesis enters. So here on the y-axis, you can see the intracranial pressure, and on the x-axis, we have the intracranial volume. Okay. Now, for example, this is the normal intracranial volume. So we have 10% CSF, 10% blood, and 80% brain tissue. Now, if this is the normal situation, then we have a normal intracranial pressure. Now, on this next slide, we can see here that there is brain tumor. So there is increase in the brain tissue. What happens? It will push the blood volume, or the blood volume and the cerebrospinal fluid has to be decreased. So pag nag-decrease sila, okay, we are still able to maintain the same intracranial pressure. What if the brain tumor enlarges? Lumaki pa siya lalo, it enlarges. So even if we already decrease the CSF fluid and the blood volume, still the intracranial pressure now is being increased because this Monro-Kellie hypothesis can no longer maintain the intracranial pressure. What if it will further increase in size? The tumor will further increase in size. We decrease the CSF and blood volume level. Still, there will be an increase in the intracranial pressure. So when we say Monro-Kellie hypothesis, in order for you to maintain a normal intracranial pressure, there will be a change in the volume of one of the compartment to offset the change in another compartment, such as this class. Brain tissue increase, then we have to at least decrease the blood volume first. So, unang compartment muna the blood volume. But next, we now adjust two compartments. So, that is the Monro-Kellie hypothesis. Pressure is normally well controlled through alteration in the blood and CSF. Okay? This is a funny class. Of course, it's the blood and the CSF that will adjust. Last na lang ang brain tissue na mag-adjust because when the brain tissue is the one that is adjusting, it only means that herniation already happened. Okay, now we have here the brain pressure and volume curve. Okay, so this is very easy to remember. It's also just the same as the ones we've been telling earlier. As the volume in the brain, inside the brain compartment increases, the pressure will also increase. If there is increase in blood volume, there will be increase in pressure. If there is increase in CSF production, but there is no reabsorption of the CSF, then the intracranial pressure will increase. If there is a brain tumor, therefore the brain tissue is increased, then the pressure also will be increased. Naintindihan ba natin, class? Did you get that?
Yes po.
Yes, Doc.
Okay, thank you so much for those who are answering me. All right, next, we have the pressure and volume curve compliance. So it's here that we can see that the extent of the change in intracranial pressure caused by an alteration in volume of the intracranial contents is determined by the compliance of the brain. So we have what we also call your brain compliance. So in other words, class, if we have low compliance, the brain is stiffer or less squishable. And if there is increasing blood volume, it will result in a higher rise in intracranial pressure than if the compliance was high. So that is the term compliance. So the compliance of the brain means the degree to which it can adjust or accommodate and increase in the component in another cranial compartment. Okay, now there are different scenarios or condition increasing intracranial pressure. The first one includes your conditions increasing blood volume. Okay, so these conditions are very, very important to take note. So first we have your intracranial mass or tumor. Pwede ding hematoma, aneurysm, or atrioventricular atriovenous malformation. So we have here a parasagittal tumor, a tumor in the olfactory groove, suprasellar tumor, clavus tumor, tumor in the foramen magnum, a cerebellar tumor. Okay, so we have here another condition is cerebral edema if the brain tissue is edematous. Or a CNS infection. If there is infection of the brain, it will develop abscess, and this abscess will also occupy space, and also inflammatory processes. So this will increase blood volume. Other conditions naman will increase, brain volume pala ito. Now we take note of those increasing blood volume. So if there is obstruction of venous outflow, if there is hyperemia due to decreased oxygen, which will then increase cerebral blood flow. If there is increase in carbon dioxide, it will cause vasodilation, thereby increasing cerebral blood flow and cerebral blood volume, consequently increasing intracranial pressure. So for example, here we have a hematoma, or hemorrhage rather, which will then cause herniation of the central transtentorial tonsils, pwede ding uncal herniation or transcalvarial herniation. So I remember class, 7 years ago, I was a medical student. My father had subdural hematoma and he had to underwent cranial burr holing. So that was 7 years ago. It was a little stressful for me at the time because I was a medical student. I had to be absent for a week in class because I had to go in Manila and assist my father in the operation and after operation. So it's very important for you to understand, class, why it's important for you to know the different components of the intracranial compartment and how it will affect the other compartment if there are increases in the other compartment. Okay, we also have other conditions increasing cerebrospinal fluid volume. For example, if there is increased production. So anong sabi natin kanina? We said the choroid plexus produces 70% of the cerebrospinal fluid. And if there is a papilloma, meaning there is a tumor or a growth in the choroid plexus, then meaning it will produce more cerebrospinal fluid. Another cause would be decreased reabsorption of cerebrospinal fluid, such as when you have meningitis or subarachnoid hemorrhage, or an obstruction in the CSF flow. For example, if there is a stenosis in the cerebral aqueduct. So we have here, class, it shows us an enlarged lateral ventricle as well as an enlarged third ventricle because of an obstruction. So the obstruction may be in the form of a lesion as well. So the flow is obstructed, therefore it will accumulate. So this will increase the CSF volume inside the brain and therefore increases intracranial pressure. So we can see here, class, the summary of what we have been discussing earlier. We have the meningeal barrier, the blood-brain barrier, and as well as the blood-CSF barrier. Now let's talk more about the blood-brain barrier. So the blood-brain barrier, as we have mentioned earlier, is consist of your endothelial cells of your cerebral capillaries. So this is a capillary, and then it is surrounded by, of course, the endothelial cells. So in between them, there are tight junctions here. So these are your tight junctions. And we can see here as well the foot processes of your astrocyte or your astrocyte and feet. So this is what consists of the blood-brain barrier. So this is the blood, and then surrounding it is the brain tissue. So these are your capillaries, and then surrounding it is the brain tissue. So that's why we call it your blood-brain barrier. Now, what is important to take note is the function of your blood-brain barrier. Why is this blood-brain barrier important? We have here your capillary, we have here your neurons. So this blood-brain barrier maintains a constant environment for our neurons. And of course, it will also prevent the escape of neurotransmitters. Now, what you need to take note, class, is that there are certain drugs that can penetrate this barrier to a various degree. And if it is a lipid-soluble drug and a non-ionized drug, it is easier to penetrate the blood-brain barrier. So this is very important to protect the neurons from the escape of neurotransmitter and from other toxic substances as well. Now, the blood-brain barrier, where can we find it? So it can be found in all areas of the brain, but there are certain exemptions. So we have these exemptions found in the circumventricular organs. So when we say circumventricular organs, so we have here the ventricles. So we have the ventricles, which contains the CSF. Circumventricular, meaning these are organs that borders the third and fourth ventricles. They are found in the midline. These are midline structures that borders the ventricles. So we have here your pineal gland. So it doesn't have a blood-brain barrier. Area postrema doesn't have a blood-brain barrier. So what is it? Why is it important to take note of this? Sa mga mahilig uminom, those who are alcoholic, those who like to drink alcohol, class, take note, the area postrema does not have a blood-brain barrier, meaning alcohol can pass through this area postrema. And if you take in too much alcohol, this area postrema is actually the area for vomiting. So what happens if you drink too much alcohol, class? What's the answer? What happens to you?
Vomit, Doc.
Correct, di ba? Yung sumagot sa akin, baka na-experience na niya yun. Did you experience
Pagdadrama
that?
muna, Doc, bago sumuka.
Ano, no?
Pagdadrama muna, Doc, bago sumuka.
Okay. O kaya mag-English, di ba? Mag-English muna. So anyway, class, that is the reason why there is this area postrema is not surrounded by a blood-brain barrier. So there are also other areas such as your hypothalamus and your posterior pituitary gland or your neurohypophysis. Take note, it's very specific, class. It's the neurohypophysis, not the anterior hypophysis, or the anterior pituitary gland rather. Now, okay, I think this is my last slide for this lecture. We have also what we call your blood-CSF barrier. Okay, blood-CSF barrier, meaning, of course, this is between the blood vessel, it's between a capillary and that of the cerebrospinal fluid. So this is composed of your choroid plexus epithelium. So these are made up of your tight junctions at the ependymal level. And parang mali ito. Ano ba? Tama pala. So we have here the fenestrated junctions at the capillaries. We have a stroma in between, and then we have your choroidal capillaries. So take note, class, this is also important for maintaining the components of the blood and with that of the cerebrospinal fluid. Okay, so I'd like to end my lecture by showing you this picture. I just saw it on Facebook. So this is the medical student, and this is how med school will feel like. I don't know if you already feel this on your first year of med school, and also during this time of pandemic that you have online classes. But this is really how it will feel like. And yan, ganyan, diba? Kinakaya niya. So what I would like to say is, you can also do it. Okay, kayang-kaya nyo rin yan, class. You just have, of course, to focus and then dedicate your time studying and less time for leisure and other things. And of course, as Polinian medical students, I want you to remember that you have to really take this medical classes seriously, even if it's just online. You really have to listen to it because this is the best time for you to learn. Okay, so that ends my lecture for today.